Hi, everybody. My name is Joel Spicer. I'm the President Chief Executive Officer of Nutrition International, a global nutrition organization headquartered in Ottawa, Canada, but with operations in Africa and Asia. I want to thank you, Luchika, for the opportunity to address this group today. And I should start by explaining why a nutrition guy is even talking to you at all. There are two reasons. The first is for those that may not know me or knew me but can't recognize me anymore because I'm old and it happened 10 years ago. I used to work for the Stop TB Partnership, and the first half of my career was in infectious diseases and in tuberculosis in particular. So I'm kind of like a TB guy trapped in a nutrition guy's body. And the second reason is Anurag sent up a flare. And what I mean by that is the ration study was so extraordinary in demonstrating that if you added nutrition packages to household contacts of people with infectious TB, you could actually reduce TB transmission or TB incidence by about 40%. That's so extraordinary that it sent up a flare that got even higher than the very high walls of the tuberculosis community silo, so that we could even see it from the nutrition community silo from our side and see that it was relevant and interesting and worth pursuing. So thank you, Anurag, for that. I look forward to meeting you in person one day. The problem is we're also convinced in our different communities that our issue is of paramount importance, that we often fail to see the issues that we're trying to advance come together in the very same people that we exist to serve. And because we're structured and financed and our mandates are separate, there's really no incentive or very few things that encourage us to come together to solve hard problems like how to bring tuberculosis and nutrition together properly and at scale in a way that has effect. But it's still our duty to the people we serve to try and solve these problems together. Quick story. In 2007 to 2010, I worked at the World Bank. I was the only guy working full-time on tuberculosis. There were about 40 or 50 people working full-time on HIV/AIDS. And part of my job was reviewing project appraisal documents, long documents that are necessary to get projects approved. And we're talking about billions of dollars going out the door for HIV/AIDS. All very important work. One of the things I used to do was do word searches for TB in these documents, hundreds of pages. And the most common occurring word was the word textbook, because it has TB in the middle, not TB itself or tuberculosis. And so for the largest killer of people living with HIV/AIDS to not be referenced, to me, struck me as an egregious missed opportunity. And it's thanks to the World Bank that I have an allergy to missed opportunities. That's coming into this conversation too, because we're missing opportunities between the TB and nutrition space. How do we operationalize those? Our ideal end state is that we have people working in TB who are passionate about nutrition because they know why it's important for their issue, and vice versa. Right? But the fact that undernutrition and diabetes are major drivers of tuberculosis means they can't be ignored. Diabetes is the new HIV. With 800 million cases around the world and rising fastest in low and middle income countries, especially those with TB, we know we're going to see another situation where it becomes more and more difficult to put the genie in the bottle. Donors are key actors in this, but they've got to be prepared to fund differently also. But most of them are structured to create silos too, internally, by having different teams. So what can we do? Nutrition is obviously important for people who are already infected with TB, but what the ration study helps us imagine is what might be possible on the prevention side of the equation, particularly for high-risk populations that don't yet have TB. So as good as it is to develop new and better treatments, and from our side of the wall, it looks like the TB community has been very successful in pursuing this, well done. We know we can't treat our way out of tuberculosis in the same way we can't treat our way out of malnutrition. We've got to focus on the full suite of interventions that are on the prevention side. And nutrition is a major potential contributor to that prevention side of the ledger on TB. So we've got to get it right. Other things we can do. Here's an example from the nutrition side that maybe is something we can offer. We've been engaging heavily in social protection systems over the last several years, given their explosion in COVID. Right, as a response to COVID. And we noticed that hardly any of them are optimized for nutrition outcomes, which is ironic because they're targeting the people that have the deepest pockets of malnutrition in many cases, right? Probably of TB too. So our response has been, I'll give you one example, in the public distribution system in India, for example, to work with government to fortify the ration that people who benefit from the public distribution systems get, right? So they can get fortified cooking oil, fortified rice, fortified wheat, double fortified salt in some cases, not everywhere yet. And we hope that that is providing them some additional nutritional benefit. But you know what we're not doing? We're not thinking about or talking about what happens if that person comes in to get their food ration every month and they're coughing, and how to take advantage of that contact point to do a simple cough screening test or a portable diagnostic test, and then to follow them home to their household that has people in it that are at high risk, maybe even highest risk of TB transmission, apart from prisons and mines. So that may be an example of something we can get together on a little bit more. Other examples. What about artificial intelligence? Everyone in there and their uncle is working on how AI can help contribute to the issue they're working on. But can we use AI for better identification of joint risk and vulnerability? Can we prioritize areas with highest malnutrition that also have the highest incidence of TB? Can we bring TB modelers and nutrition modelers together to build costed policy options for decision makers at country level so they can understand what it's going to cost and what the benefits are of that investment to trying to bring nutrition and tuberculosis closer together? And maybe they can also understand the cost of inaction. What will happen if they do nothing? These are things we can do. We've got a health economics unit that's been active for 5 years that works full time on this. And we know that you're working on these questions too. So can we also put our voices together and begin calling for a new way of doing business in nutrition and tuberculosis together? Because maybe if we put those voices together and decide to come up with some actionable and investable ways of moving forward on this, we can begin to move the needle on the TB and nutrition agenda in a way that adds value to both. So following meetings in Geneva a couple of weeks ago with Luchika and team, we're going to continue exploring areas of collaboration with Stop TB in line with some of the examples that I've just mentioned, right? But I have to note, we're not funded to do this. It's not in our mandate. It's not in our operational priorities. It's not in our research priorities. But 6 out of the 8 high-burden countries for TB are countries that are of high interest to us because of malnutrition there as well. And so there's a possibility that if we work together, we can help a lot of the same people we're focused on more efficiently and more effectively if we can bring the TB and nutrition stories together. So please keep prioritizing this issue. Please keep sending up flares. Thank you for listening. Be well.